All right, I'd like to welcome everyone today to the Baltimore County Fire Department EMS Academy Training Series. Today's topic is seizure management in the pre-hospital arena. This is by Dr. John Dunford. John is both a neurologist and an anesthesiologist, therefore a neuroanesthesiologist. He did his neurology training at Letterman Army Medical Center and his anesthesia training at Johns Hopkins. And he went from there. After serving in the U.S. military, he stayed as a civilian at Walter Reed National Military Medical Center in Bethesda, where he was a section chief for neuroanesthesia. He also works at Johns Hopkins, and he's faculty at Uniformed Services University School of Medicine. He gave us a talk similar to this back in 2017, I believe, and he's agreed to join us again today for a little update as things have changed over the last several years. So without further ado, I'd like to welcome John M. Dunford for his talk on seizure management.
Thank you, Dr. Sagal, for that kind introduction. Ashley, can you hear me okay?
Yes, thank you.
Okay. Listen, thank you very much for the invitation to come speak about the pre-hospital management of seizures for for Baltimore County Fire and Rescue. My name is John Dunford. I'm a neurologist and an anesthesiologist. I want to give a shout out to two people, Dr. Jeff Sagal, who just introduced me, and Dr. Sean Barron-Holtz, both with the Baltimore County Fire Department, both of which I've known for a very long time. Dr. Barron-Holtz I've known since 1996 as a colleague at Johns Hopkins, and Dr. Sagal I've known almost as long as a colleague at Walter Reed, both of which I respect their clinical acumen very highly, and they are good people. Again, thank you very much for the invitation. In addition, we're going to be looking at some videos from YouTube. I want to reinforce the fact that I'm not getting any reimbursement for this video, and I have no conflicts of interest. I have no financial interest. And I also want to thank the people in these videos, their families, and the individuals that are seizing in these videos for letting us view them and learning by them in advance. So let's start. First, I want to go ahead and look at this video for a minute. Let's see if we can get it to go without an advertisement. Let's see if we can get this to go. Bear with me. Just to set the tone for our meeting. Oh, I think I might have lost it. So let me go. There's gonna be a small advertisement here. I think it's the only advertisement for the during the presentation, though. So let's see what I can do. It's going to be about 5 seconds here. Liberty, liberty, or something. Oh no, here it goes. All right. I want you to study this child for a minute.
Carefully.
Now, when we look at the child, we see he's not in there. We also see clonic activity in his arms.
Is he hot? You'll find a thermometer.
Mom's concerned about his temperature. Now, right off the bat, when we see a seizure, we'll be timing it. This seizure so far has been about 39 seconds on the video. We see clonic activity in the legs and clonic activity in the arm. We see the child staring off. And as we take care of the child, we think of basic life support things. We can ask ourselves, is the child breathing okay? Is he oxygenating okay? Is he have adequate blood pressure? Is he perfusing his brain with blood? And what's his glucose? Do we need to check a glucose? We're always going to think that. Basic support things that families put the child on his side.
Hey, buddy. Hey, buddy, we're here.
And they're checking a temperature.
100 right now.
Let's give it another minute.
Hey, buddy.
The child has a temperature of over 101.
You okay?
And he's starting to come around. So far, this has been 1 minute and 50 seconds. Now listen to his airway now. This is important, I think. As the seizure progresses, you'll see he doesn't control the secretions and he has trouble swallowing. He also may have an mild airway obstruction. This is very common with seizures. Near the end of the seizure, you'll see that in some other videos. So this is a febrile seizure. This typically happens between 6 months and 5 years. 10% of children can have this. 35% could potentially have another seizure if they've had one of these. The thought is that some children at this age don't have as much insulation in their head. They don't have enough myelin, and they may be predisposed to seizure when they have an increased temperature. What you don't do is take the child and put them in cold water. That's usually not suggested. We don't usually go ahead and use any Tylenol necessarily. I mean, of course, you could use Tylenol, but not to necessarily treat the seizure. And we can see then that the seizure is self-limited, and at 2 minutes, 59 seconds, or about 3 minutes here, the child's no longer seizing. All right. So this is a basic start or seizure that we can use to evaluate what seizures are like or look like. So what is a seizure? A seizure is an epileptic seizure, or otherwise known as a fit, is due to an abnormal, excessive, or synchronous neuronal activity in the brain. How I like to think of it is my brain is like a circuit breaker box in my house. And imagine when I put my circuit breaker box in, one of the wires doesn't have enough insulation for the current going through it. And if that one wire gets excessive electricity going through it, then you could get a short. And if the short spreads to the other wires, it could spread throughout the whole circuit breaker box and short circuit the whole thing. And this is what I think the brain is doing when you have a seizure. Now let's look at what is happening perhaps in this child's head, potentially, or anybody that happens to have a seizure. We know that the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. So if you look in this slide, we look at the temporal lobe up to the right, and we can see there potentially is a scar, and that's where the seizure is starting. This is a focal seizure. The short circuit is right there. As it progresses, you will see that since the seizure is just in that one temporal lobe, the patient still has consciousness preserved. But the patient may get some fear, déjà vu sensation. They may have complex automatisms. They may feel the need to urinate. They may chomp their lips. They may have gastrointestinal trouble. Either way, that is a focal seizure. Now, as the seizure spreads to the other side, then we get tonic activity, and we get a stiffening of the extremities. We start to lose consciousness. During this tonic phase, the blood pressure potentially can drop, and most importantly, the heart rate can slow down. The tonic phase is a vagal phase. In other words, you get bradycardia and slow heart rate with that. And then the seizure continues and the brain stem's affected. And then we get clonic activity, and we'll have the shaking that we anticipate with seizure. The patient may bite their tongue. We saw that clonic activity in that baby with the febrile seizure. If you look at the EEG here at the bottom, we can see that the right side is slow, so there's a focus, and then it spreads. And on the EEG, we can see where this spread has occurred. Now let's contrast that with an absence seizure. An absence seizure, or a primary generalized seizure, as opposed to the one we just saw, where a small segment of brain is where the seizure starts. In this kind of seizure, which is often inherited, the whole brain seizes all at once. So if you look at the EEG down here, it's relatively flat, and all of a sudden the whole brain seizes, and then it stops. And what'll happen, the child in this case, between seizures is totally alert, then they can stare off, their eye fluids might flutter at 3 per second because that's the EEG frequency of an absence. And then, as if nothing happened, they come right around again. This is a primary generalized seizure. So when we look at our classification of seizures, we can see that we can have either a focal onset, which we saw in our first Netter slide, and where the seizure starts in one section of the brain and spreads, or we can have generalized onset, where the seizure starts, it goes into the whole brain at once and then immediately goes away. Now, when the seizure is focal, if the seizure area that's seizing is right over a motor area that controls the arm, well, then the arm might move. If it controls an area that is receptive for speech, you might not be able to speak. If it controls an area that has in the back of the head, and you might have trouble with vision. Then, of course, it will potentially spread, and if it spreads, then it will can turn into a focal bilateral tonic-clonic seizure. So we have a generalized onset and a focal onset. Now, let's look at this seizure. This seizure is going to be about 4 minutes. I kind of want to go through it in its entirety, so all of us can be aware of what a seizure looks like from start to finish. Obviously, this woman is reading, and she's on a monitored bed, most likely in an epilepsy ward. She has an EEG on her head, and they're monitoring her.
Okay.
Now look, she pushes the button. The right hand isn't moving, but the left hand can, okay? As much.
Have a seizure?
So she knows, she's aware. She knows she's having a seizure, so it's still focal right now.
Have a converse?
So they started the timer. According to our thing, we're potentially 45 seconds into the seizure. Now the head is turning to the left, most likely.
Wait, help you. Can you send the nurse? She's having a seizure.
The eyes are turning to the right. And what this means most likely is the left side of the brain is starting with the seizure. Now we have some rigidity in the left. And we'll start to finish that clonic activity on the right in a minute. And let's see where that comes out. Notice how calm the nurse is.
Having a seizure. Right.
So for our basic life support management, it's supportive care. Is she getting enough oxygen? Is she breathing okay? Is she perfusing her brain? Does she have adequate blood pressure?
2 minutes, brace right at the time.
We're now 1 minute and 50 seconds into our seat. Remember, now the brainstem is affected and she's having trouble swallowing, or taking care of her secretions.
Every time we need to turn her over.
You can see how long this is after the beginning of the seizure.
Kara, you have a phone call at the desk. Kara, telephone call at
So
the
she's
desk.
still having some clonic activity. We've timed our seizure at 2 minutes, 30 seconds so far. We have to ask ourselves, should we check a sugar or glucose? Every BLS provider needs to think, do we need to check a glucose? Now she's in a, here comes the airway stuff, right? You can see the obstruction of the airway, and it happens later.
It's also not
Very
a
common.
thing. Oh.
She can't handle her secretions.
And tell somebody to come back and get our suction set out, please. It's supposed to be set up.
Again, this would be alarming if you first showed up right now, thinking, oh gosh. Do we need to get supplemental oxygen and or breathe for it? But this is very transient. It should get better here in a minute. And it's unexpected. You see the nurse feels very comfortable. Our seizure now is at 3 minutes, 38 seconds.
Oh, I didn't know I was on phone.
Now she's able to breathe a little better. She's going to start to become more aware.
Oh, they set his room up. I know, it's not suction.
And our seizure has lasted
Yeah, it's
a
okay.
little less
Sister.
potentially than 4 minutes, and then she looks fatigued. So she's post-ictal.
Thank you.
This is a very classic, typical seizure. So far, we've looked at a febrile seizure, and we've looked at a partial or focal seizure with secondary generalization. But remember, we have to think of other reasons why someone could seize, and this could be another one. This gentleman's hyperventilating. I don't know if you've ever done this as a child. I know we did. But nevertheless, that he was going to hyperventilate, this boy hyperventilates. Now the blood is rushing to his feet. And now he's going to have some clonic activity. This is a syncopal seizure. The time you're going to see this is in phlebotomy in the hospital. Somebody is getting their blood drawn and they are not able to lay them down, and they will go ahead and have a syncopal seizure. Let's look at this one. Here's another syncopal seizure, which I think is very interesting.
Så, nu sitter helt rakt. Sådär ja.
This gentleman is getting his eye pierced. Look, he's looking lightheaded.
Jag har inte dött än.
They lay him down.
Ja, lägg dig. Han blev snabbt upp med fötterna.
Get a tonic. Now he's clonic with the mild clonic jerks. Now he comes around, right? But now watch this. Our seizure is going to come back.
Ligg ner. Ligg ner.
Ligg ner då. Det är lugnt. Det är lugnt. Det är lugnt.
Du får ligga ner.
Lägg med huvudet ner. Så, slappna av.
Vi lyckades inte lura.
He's laying down, but rarely you can get vagal while you're laying down, have a very slow heart rate,
Visst, det var
and get a syncopal seizure laying down. It's very rare, but this guy has it. You'll see it in a minute.
Nej, det är ingenting.
Jag har sett det mängder. Ligg ner bara.
Irriterande. Jag tycker det går roligt, ja. Nej.
Blir det så när du tar vanliga
Pulling that out.
Ja, det är så vanligt.
He's pale.
Du tycker inte om det?
Nej.
Men varför kommer du pierca det då? Du tycker om detta?
Unconscious again.
Ja, du har ju ingen bra färg överhuvudtaget där nu tycker jag. Är du kvar? Han försvinner igen.
And he's got more mild clonic jerks. Okay. Syncopal seizures. Now let's look at an absent seizure. This is a primary generalized seizure. I don't have a way to maximize this screen, but let's watch this baby. Baby staring off.
Lachlan. 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 Lachlan.
Lachlan,
Lachlan.
Lachlan,
Lachlan.
Lachlan,
Lachlan.
Lachlan,
Lachlan.
hey,
Lachlan.
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 And baby's back. Okay. So again, a primary generalized epilepsy. So what have we said? We've had absence. We've looked at a syncopal seizure with not enough blood going to the head. We've looked at our video of the woman who seized in the EEG suite. And then before that, we looked at our seizure that was associated with a fever. Now, again, we see that typically in seizures, the focus, we have a focus for focal seizures, we have a focus, it spreads to the other side of the brain. The brainstem gets involved. We have a generalized seizure. You have the tonic phase, which gives you bradycardia. You have the clonic phase, which gives you tachycardia, or you have an absence seizure. Now, usually these are short-lived, but let's say that they last more than 5 minutes. If they last more than 5 minutes, we're going to call it status epilepticus. So status epilepticus is a single epileptic seizure lasting more than 5 minutes, or 2 or more seizures within a 5-minute period. Brief seizures are defined as lasting less than 5 minutes while prolonged seizures last between 5 and 30 minutes. So status epilepticus is a type of prolonged seizure. It used to be that there was an older 30-minute definition. So when I trained, that was the definition. It was based on 30 minutes being the duration of convulsive status that caused permanent neurologic injury. So again, if you have status epilepticus or you seize for more than 30 minutes, you can get irreparable brain damage. Now, between 50,000 and 150,000 Americans each year have status epilepticus, but with mortality estimated at least 3% in children and up to 30% of adults. The goal of therapy is the rapid termination of both clinical and electrical seizure activity, since appropriate and timely therapy of status epilepticus reduces the associated mortality and morbidity. And this is how we as EMS providers can potentially help these people. Status epilepticus, 61% of the seizures that last 5 minutes will last 60 minutes. The morbidity without treatment. The morbidity and mortality is high if your seizure lasts greater than 5 minutes. The most common cause is the patient forgot to take their anti-epileptic medicine. Since the majority of seizures are brief, and once the seizure lasts more than 5 minutes, it's likely to be prolonged, status treatment protocols have used a 5-minute definition to minimize both the risk of seizures reaching 30 minutes and the adverse outcomes associated with needlessly intervening on brief self-limited seizures. So we're using 5 minutes as the cutoff. Now, what kind of status epilepticus can we have? We can have convulsive status epilepticus consisting of repeated generalized tonic-clonic seizures with persistent postictal depression of neurologic function between the seizure. We can have a non-convulsive status where seizures produce a continuous fluctuating twilight state. In other words, you can be a status epilepticus without frank clonic seizure activity. Or you could have repeated focal seizures where one little segment of the brain seizes and seizes and seizes, but you don't lose consciousness. So you might have focal sensory symptoms or focal impairment of a function like aphasia, they can't speak, but it's not associated with altered awareness. This is called epilepsy partialis continua if you have a status epilepticus of a focal seizure. Now let's look at the American Epilepsy Society guidelines for the treatment of status epilepticus. We're going to compare this to the Maryland protocol in a minute for the management, pre-hospital management for ALS and BLS and ALS providers. But here, this is what the American Epilepsy Society suggests as the treatment for patients with convulsive status. This is going to continue all the way into the hospital, but I want to go through it so that the EMS provider knows eventually what's going to happen, especially once the patient's dropped off in the emergency department and they continue to seize. So first, in the first 5 minutes, the American Epilepsy Society says we need to concentrate on stabilization. This is what a BLS and ALS provider can do. First, we have to make sure that they're oxygenating, ventilating, and they have an adequate blood pressure. We are going to, if not, we're going to assist in those facets. We're always going to think, do I need to check a sugar glucose? Anybody that seizes more than 5 minutes, or I'll challenge you, by the time an EMS provider arrives and they're still seizing, we need to be checking a glucose. If the glucose is less than 60, then you give thiamine and you'll give D50. If it's if children greater than 2, you'll use 2 mLs per kilo of D25, and children less than 2, you get 4 mLs per kilo of 12.5. But nevertheless, we have to always make sure we think in terms of glucoses. Then we're going to think, what else could cause a seizure? Could the patient have fallen? Could they have a hemorrhage into their head? Could they have stroked? Do they have an electrolyte abnormality? But most importantly, for the EMS provider, we need to check a glucose. Now, if the patient's seizing more than 5 minutes, we now know the patient's in status epilepticus. Our transport time may be more than a few minutes, and therefore the ALS provider needs to have the ability to go ahead and treat status epilepticus. And the protocol here from the American Epilepsy Society states that a benzodiazepine is first, and you can use IM midazolam, 10 milligrams for over 40 kilos, or 5 milligrams from 15 to 40 kilos in a single dose. You can do intravenous lorazepam or intravenous diazepam. Studies have shown that IM treatment is just as efficacious with midazolam as IV treatment with midazolam. So if you don't have an IV, you can easily use your IM or intranasal midazolam. We'll see more about that in a minute. That being said, intravenous phenobarbital, rectal diazepam, and intranasal midazolam can also be used. If a child, for example, has seizure disorders and they're repetitive, the pediatrician may give the parents intranasal midazolam or rectal diazepam to use to stop the seizure. If that's the case, obviously the EMS provider can facilitate the parents or recommend to the parents that they can use their already prescribed medications. Now, if benzodiazepine does not work, then we're going to be transporting to the hospital, and typically in the hospital, either one of three medicines is going to be used to stop the seizure. It's going to be levotirazepam, which is Keppra, valproic acid, or fosphenytoin. For me, in my experience, levotirazepam is by far the most commonly used medicine. But again, valproic acid and fosphenytoin can be used. If someone doesn't have that, then you can use phenobarbital. Now, if that doesn't work, then what's going to happen is we're going to do a general anesthetic. And most typically, propofol is what's going to be used. The patient will be intubated, and the patient will put on a propofol drip. They'll get an EEG, and they'll go to the intensive care unit. And and it will be an aggressive look to try to help determine why this person is still seizing. So what are the drugs that we use for status epilepticus? This is the benzodiazepines, midazolam, lorazepam, and diazepam. We will visit them more when we look at our the Maryland guide for for EMS providers in a minute. But if those don't work, then we're going to use an anti-epileptic drug. If that doesn't work, you're going to call anesthesia. You'll get propofol. The patient usually will be intubated, and the patient will go to the ICU. Now, there's a specific exception for seizures in patients who are pregnant. In addition to the use of benzodiazepines, magnesium 4 grams can be administered. We'll look at that more in a minute. Now, let's look at this video and decide whether or not you would call an ambulance if you were in the position of this guy's friends.
No, he won't. He'll start breathing through his nose. Song, yeah, dude. Yep. I need help. He's breathing. He's breathing. He's breathing. Should she call 911? No. Don't do it. Don't do it. Don't do it. I've done this before with him.
This is right
The only
decide
rule
whether
is
to
this time
activate
he requests
EMS.
me to film it.
You look at the time,
He's never seen
it's
film
31 seconds.
Okay. No, he's breathing. He's good. Yeah, he's coached me through this 1.5 million times before. Just make sure he's not choking. Make sure he didn't hit himself too hard. Make sure he's breathing the shit. And make sure he's not hitting shit.
Listen to the breathing. Very common to
I'd say
have
it's gonna be
somewhat
done in about
obstructed
30
breathing,
seconds
as I've
to a
talked
minute.
about before. Now it's obstructing a little bit more.
Pat, you hear?
Very common. This stresses people.
Yes. Yeah.
What's the address?
Miller's Park. Hey, if you want Miller's Park Road, she's calling for help right now. Yeah, we're here. We're here, Pat. Pat. Pat, can you hear us?
I need an ambulance right away. My second cousin
It's bleeding. Right here, dude.
Okay, don't hold him down. Okay. Okay. Yeah.
Pat.
Can be on his back or?
Can you hear me? Yeah. Hey, he's fine. He's fine.
Okay.
So this seizure is less than 2 minutes.
No.
So again, it's very easy to call a paramedic. And I had a family member who had epilepsy when I was growing up. And the epilepsy society he would go to, they were so frustrated because all these people would call ambulances when they'd seize. And they'd wake up in an ambulance and get a huge ambulance bill. And one of the epileptics in the Epilepsy Society used to wear a sign, and it said, if you call the ambulance, you pay for it. So again, they obviously we want to allocate our ambulance resources appropriately. Now, let's look at the pre-hospital management of status epilepticus using the Maryland Medical Protocol for Emergency Medical Services. We looked at the guidelines, the national guidelines from the neurologists, but let's see what we have here in Maryland. If you look into the book, you'll see in the table of contents, there's 2 pages here on seizures, seizure treatment for adult, and seizure treatments for pediatrics. If you dive in, this is what the page for the adult looks like, and this is what the page for we'll look at the peds one in a minute. So let's look at the adult one. At the top, it says indications for this page. In involuntary repetitive muscle movements, usually abrupt in onset, so I assume they're talking about a seizure, observed seizure activity, decreased mental status, unconscious, incontinence, head injury. I have to admit, this is a little challenging, I would think, to look at those specific things and come up with epilepsy based on that list. But nevertheless, when we do want to make the proper diagnosis of seizures, and this is why we're watching these videos. Now, for the BLS provider, we want to make sure if the seizure has stopped, we can identify and treat injuries, and we need to potentially check to see if we need to check a glucose. When in doubt, check a glucose, make sure that it's over 70, otherwise administer glucose paste. The patient is still seizing, don't restrain the patient, don't put anything in their mouth, protect them from injury, and then try to figure out what the causes are. And what could the cause be? They're not breathing, they're hypoxic, they're not ventilating well, the blood isn't going to their head, so they're syncopal, like the heart's not beating well, or do they have a stroke? Not enough blood's going to the head because they've had a stroke, whether it's a hemorrhage or ischemia in the head. Did they fall from a height and now they have a contusion? Were they in a motor vehicle accident and they hit their head and they're seizing because of that? Or is this alcohol withdrawal or some sort of drug abuse? All these things we're going to think about at the BLS level to try to determine what is going on. Now, for the active seizure, for the ALS, we're again going to go ahead and check that sugar. If not, we're going to start with midazolam, intramuscular or intranasal for patients with active seizures. Now, typically, the protocol is 5 minutes. We'll see in the peds section, we may wait 10 minutes, but nevertheless, 5 minutes is an appropriate amount of time. The IM or intranasal is 5 milligrams, IM route preferred. The IV is 0.1 mg per kg in 2 milligram increments, so give 2 milligrams at a time with a maximum dose of 5 milligrams. If someone's over 69, drop the dose in half. You can use diazepam if you don't have mid-az. Pregnant women, again, think about the mag sulfate in addition to the benzodiazepine. Now, they have a caveat here. They say midazolam, consult if you want to give more than 5 milligrams, call up and get a doc to help. And diazepam, they're in the nerve agent antidote kits. There are IM midazolam doses, it seems. So again, if you want to use it there, you can. Otherwise, if you have to use diazepam, go ahead and get a doctor to help. But most typically, you use midazolam. And magnesium, again, pregnant ladies with seizures, we need to have a low threshold for that. Now let's look at children. What's the difference? Well, in children, same. We're going to go ahead and check a sugar. And then again, try to determine what is potentially causing the seizure. Is there not enough ventilation? Are they hypoxic? There's not enough blood going? Are they syncopal? And did they hit their head? Could it be a drug of some sort? Are they infected? Either way, we'll try to come up with an etiology. And then for the ALS provider, in addition to checking sugar, again, you're going to use midazolam. Now, the midazolam, instead of 5 milligram in the adult, you're going to use 0.2 milligrams per kilo intranasal or IM. Maximum dose is 5 milligrams, IM route preferred. Again, we've had studies have shown that IM route and IV route work just as well. And sometimes it takes a while to get an IV in the kit. So go ahead and give it IM. If there's rectal diazepam that can be used, and typically this is a drug that is not uncommonly given to parents to treat their children in case they have seizures at home. Pregnant women, again, pregnant peds women, you're going to think about using the magnesium sulfate. Now, let's look at the ALS pharmacology in our Maryland guide, just to see what the Maryland guide specifically says about these different drugs. First, we have to look at the normal vital signs. When we looked at that febrile seizure up front, you could look at that child. The child's probably about a little over 1. And want to call your attention to the fact that 1-year-olds weigh about 10 kilos and 5-year-olds weigh about 20 kilos. In this case, this algorithm has his 6-year-olds weigh 20 kilos, but 1-year-olds weigh 10, 5-year-olds weigh 20, and 8-year-olds weigh about 25 milligrams. If you look at our dosing, 0.2 mg per kg, therefore, if you look at the math, a 1-year-old should get about 2 milligrams, a 5-year-old about 4 milligrams, and an 8-year-old will get about 5 milligrams, which is the max. So we know how much to give because we need to be able to administer our midazolam with confidence. Now let's look at an 8-year-old who we want to give midazolam to, or an adult want to give midazolam. Midazolam comes in 5 milligrams per 5 mLs. So when we do an IM, that's a lot of volume. We're going to have 5 milligrams we're going to be sticking into an adult or a child less than over 8's arm. Where we stick it, up in the arm, or in a infant or toddler, we can use the thigh. So again, in our febrile seizure, if that continued, the kid continued to seize, we could use the thigh. But nevertheless, these are the locations that we use for IM injection. So in summary, for our benzodiazepine, we have midazolam 0.2 mg per kg, maximum dose 5. For IMI and intranasal, IO and IV is 0.1 mg per kg. So use 2 milligram increments, slow over 1 minute, max 5 milligrams. Then we have the diazepam, and then we have the magnesium. Now, let's look at some other types of seizures or things for us to consider. Let's look at this young lad's seizure.
Oh, I'm gonna, for a special episode, I've been reading up on Pokemon stuff right now because I used to play a lot. So I got the banned seizure-inducing episode of Pokemon. It's Electric Soldier Pyrogon. If I said that wrong, then just fuck off. It is 27-second long clip. Let's see if it works. I feel seizury today. So I'm gonna take off my fucking glasses. They're like half broken out there. I have my camera guy here. Look at the screen. Look at the screen. Let's see what happens. Okay, now look back at me.
This episode is about 1 minute long. More.
See. Yeah, I have no idea what they're saying. Look, Pikachu. Pikachu.
All right. Well, hold on a second.
This is very specifically for men over 30 years.
All right. So in this video, we saw a young lad having movements that most of us would agree are probably not a seizure. Pseudoseizures. As many as 20% of people with real seizures also have pseudoseizures. They're now called psychogenic non-epileptic seizures, or PNES. They're also known as non-epileptic attack disorders, or NEAD. These are events superficially resembling an epileptic seizure, but without the characteristic electrical discharges associated with epilepsy. PNES are triggered by psychological problems and frequently occur in a conversion disorder. Again, it is estimated that 20% of seizure patients seen in a specialist clinic may have PNES. So these are very common. Now, how can we tell whether or not a spell is ictal, in other words, from a seizure coming from inside the brain, and from potentially a non-ictal or seizure etiology? Well, let's look at what happens in our seizure. Now, we saw that in a epileptic seizure, commonly the seizure will start in one part of the brain, move to the other, have a tonic phase, a clonic phase. Now, during the tonic phase, we didn't see it in our seizures we saw here, but the tonic phase at the beginning, as the electrical activity goes from one side to the other, will often cause a contraction of the abdomen and chest, and the patient will let out a ha, a very large sigh. Ha! It's called an epileptic cry. Now, let's contrast that to a non-epileptic seizure. They'll have moaning or screaming. The vocalization is in the mid-seizure. In other words, if you make noise, you notice in our seizures, the people had trouble controlling their swallowing muscles. And so when they try to breathe in and out, they look like they're gagging. But look how far into the seizure that was as the brainstem gets affected. Often the actual clonic activity will be better by the time the patient looks like their airways obstructing. This is in contrast to non-epileptic seizures where the vocalization timing is at the beginning of the seizure. Head turning is to one side if you have an epileptic seizure, but violent side to side is what we'll have during a non-epileptic seizure. The eyes are almost always closed with a non-epileptic seizure and open for a epileptic seizure. Postictally, you're disoriented with a headache, postictal for a seizure, and then weeping or anxious with a non-epileptic seizure. During an EEG, the EEG will often show the EEG. Well, meanwhile, the electrical activity of the brain will not show the abnormal seizure electrical activity in someone with non-epileptic seizures. Now, of course, it's very easy to poo-poo someone that you think might have a non-epileptic seizure as the non-epileptic seizure not being real. Of course, to them, it is very real. And again, sometimes we have to, as providers, we have to analyze and look at ourselves, and we can think, gosh, this patient is having too many complaints, but the real reason is because the patient is very ill. The patient reads too much. Okay, the patient reads more than you do. He's got a personality disorder. You don't like him. Non-anatomic deficit. Results confuse you. Non-compliant. Treatment is worse than disease. In other words, where there's smoke, there's fire. So even with someone with a non-epileptic psychosomatic symptom to the spells, still there's something not right with their chemistry. Now, when you look at, in other words, they still are crying for help. So what are the somatic symptom disorders? These are things that happen that are not necessarily secondary to a organic illness. I want to call your attention to the upper right here of these pseudoneurologic symptoms of amnesia, loss of voice, seizures, difficulty with walking, difficulty swallowing, are things that can happen with somatic symptom disorders. Now let's take a look at this video and see what we think of the management or this girl's seizure. I'm going to move this along a little bit.
4, 2, 3, 4, 5, 2, 3, 4, 6, 2, 3. The ending. Why are you all coming up at different times? You know that last beat, you've all got to come up together. You're going to look ridiculous. Right, one more time. I'll face this way. See if that.
Yeah, this is a training video for how to take care of seizures.
7, 8.
But I want you to look at the girl who actually seizes, right?
3, 2, 3, 4, 4, 2, 3.
Now, totally stiff, no cry. Eyes are open, but look at the movement here. That's clearly not a seizure. She's got alternating hand and leg movements. Of course, the teacher's timing it, which she knows to do. She'll think, do I need to check a sugar? She put the girl who sees, they'll open the airway. Now, again, right now, if it was an epileptic seizure, she'd often be gurgling. You'd have that gurgling noise because the musculature in the back of the throat is often affected. But she'll put this girl on her side, and we now see that she's had a seizure. So again, when you look at that, we know that that isn't a real seizure. Of course, it's a training video for seizures, but we can clearly see that this was, in this case, not epileptic. All right, now let's look at this one. It's about a minute and a half. Let's watch our red shirted friend.
You want a mango or?
I was trying to communicate and this gentleman is not speaking. Look at a stiff back. To the tonic phase after the clonic phase, very irregular. Patient's hyperventilating, but there's no obstruction like the gurgling that we saw with the epileptic seizure. We got about 20 more seconds here. All right. So that also is psychogenic. However, you know, to the uninitiated, that could look pretty dang real. And let's look at one more seizure before we conclude.
Never miss a beat.
Oops, sorry about
TD
that.
clear. No interest.
Stop
Just a
this
simple
video in a
monthly
minute.
fee.
Why miss out on soaking it all in? Dove body washes. with
Sorry about
active
the
serum.
advertisement.
Get Dove or get FOMO.
Another 12,000 feet. So our lad starts to seize. Still seizing. So again, maybe this fella should not be skydiving. So what have we said? We've looked at the Maryland medical protocols for emergency medical services. We've reviewed status epilepticus. We've said that for the BLS management, we will determine whether or not we'll do our ABCs like we know to do. We'll make sure the patient's not hypoxic, that they're breathing okay, they have an adequate blood pressure. We'll assess their neurologic exam as best we can. We'll go ahead and check a sugar, and we'll look for an underlying etiology. If that doesn't work, we'll go ahead and use midazolam, most typically IM or intranasal. Other benzodiazepines are an option. And then we'll transport if that doesn't work. And in the emergency department, they will start most likely the Keppra or whatever anti-seizure medicine they're going to do. In children, same thing, except the active seizure or seizure lasting 10 minutes. They actually put 10 minutes, not 5 minutes, on the protocol for children here. When you look at for the adult, I don't see a time on there. So I'm going to use 5 minutes. but 10 minutes here, you check a glucose, and then IM or intranasal benzodiazepines. What this means is 2 cc's for 2 cc's for a 1-year-old typically, 5-year-olds 2 cc's, 8-year-olds probably is 4 cc's, and a 8-year-old will be 5 cc's, which is 5 milligrams. And again, most importantly, try to determine what the potential etiology of the seizure is, so that in other words, is the patient have meningitis? So that, again, you can facilitate the management of the patient in the emergency department. So in summary, measure the duration of the seizure. The first question is, how long is it going on? Make sure the patient is safe. Support respiration and hemodynamics. Check a glucose and look for a cause for the seizure. Seizures that last greater than 5 minutes should be treated. Midazolam is commonly used in the pre-hospital management of seizures. Don't be afraid to use it IM or intranasally. But of course, if you have an IV, you can use it through IO or IV. And remember, magnesium, in addition to midazolam, for patients with epilepsy that potentially could be preeclampsia with seizures. All right, thank you for inviting me. Do you have any questions?
Yeah. So John, if you look in the chat is a place where you'll be able to read questions where people.
Okay. Let me work on that. I need to find chat. Oh, chat, there it is.
But
Okay, I'm clicking on chat. Okay.
I'll start in that the mechanism of death for status epilepticus. You want to explain it or how?
Sure. What happens is the reason why you die from status epilepticus is because the brain outseizes its oxygen supply. So after 30 minutes of activity, it doesn't have enough glucose and machinery metabolic back reserve, so that you can't supply enough oxygen and sugar to the brain. So the neurons then become ischemic, and they start to die.
It goes into a hypermetabolic state, I think, and then
Yes, that's right. It's a hypermetabolic. So you don't have with so many neurons seizing, you don't have the ability to get enough glucose and oxygen to all those neurons so that they can stay healthy.
Right. So, and then you get cerebral edema and then game over.
That's exactly right. You'll get diffuse axonal injury, you'll have neuronal injury, you get diffuse swelling in the brain, and you can die. Now, here's the other thing. We have to think also what the etiologies for status epilepticus are. In other words, if you have encephalitis or if you have meningitis, and that's the cause for your seizure, then you're very ill anyway. And so, unfortunately, that is a part of the equation.
I always remember, for midazolam versus diazepam, it seems midazolam always had a much more predictable onset and effect than diazepam does because of the solubilities.
Well, I think what it is we use the data shows that IM midazolam is just as good as IV. IM midazolam, IM diazepam doesn't have potentially doesn't have the same great absorption in that it's not as water soluble. So again, typically diazepam is going to be given IV or rectally. It can be given IM if you have nothing else, but ideally you're going to use midazolam.
And then I always found conversion disorder interesting, and you see that a lot in EMS, and I see it a lot in the hospitals, especially more with younger people. And everyone has all sorts of little tricks they see to separate the patient from a real seizure. I mean, I have my own. I know you have yours, but it's always been interesting. But I've always found my favorite is I used to have this one patient who would all of a sudden announce she's seizing during her seizure, and we tell her, "You tell me when you're done," and we would wait, and then she'd say, "It's coming down now." It'd be great, and we're good.
Right. Clearly, if you're talking, if you can speak while both arms are moving, you're not seizing, right? You can't. It's very, very, very rare to have both sides moving and be able to speak right off the bat.
So are you able to
There are
read the
lots
chat?
of tricks for that. Yep.
So you have a couple questions for you in the chat.
Okay, let me see here. Would you attempt to place a blood pressure cuff on a seizing patient? You could do that. I mean, you could, and then just check a pressure if you feel the need. Especially if someone's laying down, most typically. Anyway, the answer, if you truly think someone is hypotensive, sure, you could try to put a blood pressure cuff on them. Or what I would do if I was going to do that, I mean, the oscillometry for the blood pressure cuff wouldn't work that well, but what you could do is just do a palp if you really wanted. Just go ahead and do palp and see what your systolic pressure is. I think that would be sufficient.
And if you scroll up, you'll see others.
Okay, let me see here. Shannon Connolly. If she was in the clinic being monitored for seizure activity, why don't they have suction or O2 available? They should have, shouldn't they? Yep. Shannon, you're absolutely right. They should have. They're bad. Next, Pikesville VFC. Please make sure to sign in using the link below. Okay.
That's for CME.
Okay. Next,
And just
Sam.
keep scrolling up. There's a bunch of questions there for you.
Okay. So Sam Weinstock. Thoughts on a benzodiazepine prior to mag sulfate for eclampsia? I know benzos are a category D. From research, it appears administering benzodiazepines for C-section is okay because of the short duration of exposure. In the pre-hospital environment, would be a while before C-section is performed. What is the true potential or harm? On the flip side, fetal mortality increases 10% for every minute of maternal seizure. Look, the guidelines are very clear on this. You use it if you over 5 minutes, you use midazolam, and then you're going to continue with the magnesium if indeed you think there's any option or the potential for eclampsia. The downside for magnesium is very low. So if my midazolam isn't working, then I'm going to be adding the mag. Clearly, because the mortality rate for someone in status epilepticus while they're seizing, I have to look at the number, but it's very, very high. And I think that's why the guidelines are specific about what they say on the treatment with magnesium of a benzo in the medical protocol, benzo followed by magnesium. Let's look at the next one. Paul Harmon.
On that one, a patient I saw who went into seizures during eclampsia, they actually erupted. A placental eruption occurred, and then the patient bled to death.
Right. It's no joke. Pregnant woman seizing is very, very challenging. Paul Harmon, again, your comments on cooling febrile seizures. It is not recommended. Now, this is not in the medical protocols, but when I look at my up-to-date for the management of febrile seizures, it is not recommended to immediately cool them. In other words, you don't take them and put them in a cold sink, for example, or you can necessarily give them Tylenol necessarily to be treating the seizure. Of course, you could be doing it to treat the fever. Fortunately, these febrile seizures are typically short-lived. One other thing that's helpful, if it's a febrile seizure, it'll be associated with a sudden increase in temperature. So a febrile seizure is classic. The kid is 98.6, and then 30 minutes later, he's 101. In other words, you have this sudden surge in temperature, and that's associated with a seizure. You're much more worried if the child's had a high temperature for a few days and then they seize, because now you're worried about meningitis or some other problem other than just the fever causing a short circuit in a child predisposed greater than an adult because they're less than 5 years old. Is that good enough, Paul? I hope. Next, Holly Georgiev. Hi, Holly. Is that when someone with a Todd's paralysis? Yeah, Todd's paralysis. That's a very good point. Todd's paralysis is after a seizure, the patient can't move or particularly an extremity, and it typically is the extremity that was most involved with the seizure. How I think of it is, let's say that I can't move my right arm because my left brain had seized, and my brain's still trying to get its stuff back together. And so it's like, hey, I'm not going to move that arm because I'm going to break because I just had a seizure and I'm in tough shape. So that is That's a Todd's paralysis. Todd's paralysis will not be typically seen with generalized seizure. They're going to be partial, complex, or focal now with altered consciousness with secondary generalization. This can be seen. Now, I want to caution you not to use flumazenil on these. Now, of course, we won't be doing this for the medical protocol in the ambulance, but let's say that someone on scene has used the rectal diazepam, and then the families use more rectal diazepam, and you don't know whether they're obtunded because of the diazepam, too much diazepam, or because they seize. If they're breathing and they're stable, don't give them flumazenil because you'll put them into convulsive status epilepticus. Flumazenil is just not the right drug for someone who's had a seizure. Carol Ann Bollard, I read an article that febrile seizures are linked to sudden unexplained death in children. I do not know enough to know about that link, whether or not SIDS is more associated with febrile seizures. I don't know enough to be able to answer that. Shannon Conley, would you attempt to place a blood pressure cuff? Yes, again, we talked about that. You can try to put a blood pressure cuff on if you truly think that the patient's not perfusing their brain and you think that's the issue, then yeah, you could go ahead and try that if you can. Sam, we got Brian's iPhone. Do you think auto-injection anti-seizure meds will be utilized here in the USA? Canada EMS is currently using? I don't know. I mean, we could do that. It's just that these auto-injections, often they get patented, kind of like the EpiPen. And yeah, we'll use that because it's got a patent pending, which would be very expensive to an EMS unit. When benzo was very easy, it's hard to really mess it up. I mean, you got 1 cc or 2 cc's, 4 cc's, or 5 cc's kind of when you go ahead and administer this. Very straightforward, I would think. Hard to overdose, but again, you could do that. But you have to look at the economics of it, I think. Robert G, as pre-hospital clinicians, would you not administer midazolam if you believe you're witnessing PNES type episode, or assume the worst and go for midazolam indicated the Maryland protocol? That is an excellent question. The downside to midazolam is very small, very small. It's an anxiolytic. And so if you're in doubt and it's been going on more than 5 minutes, I don't think anybody will fault you for going ahead with the midazolam. Yes. So yes, you can go ahead with the midazolam if you can't tell. However, you're going to be checking a glucose too. So check your glucose. If you think it's bad enough that you want to treat with midazolam, you probably should be checking a glucose. Coos. For the supine syncopal seizure, what measures, if any, should be initiated? Typically, place them flat helps. In this subset, however, that is clearly less effective. No, it is very effective to be supine. That is very rare. That seizure we just saw of a vagal while the patient was laying down is exceedingly rare. And the reason why I think it occurred is because they're pushing on the nerve above his eye. And I wonder if this is almost like a bulbar cavernosus reflex where he got bradycardic. Also, his blood pressure was probably a little low from that syncope in the first place. So he had another clonic jerk. There's a couple factors here, but as a general rule, when you lay someone down, they should be totally good. So if you are doing phlebotomy and someone has a syncopal seizure, if you lay them down, you're set. Okay, could they have 1 or 2 more clonic jerks? Maybe, yes, but if you leave them alone, they should be totally okay. Syncopal seizures are self-limiting. Fluids treat, not bradycardia. Typically, these are syncopal seizures you just observe, and sometimes you can just give them PO fluids. Use your judgment to see how you're going to manage your syncopal seizure, but for the most part, it's supportive care. Again, a classic time you might see a syncopal seizure other than in phlebotomy is someone who has mom and child have diarrhea and they come into the emergency department and the child's being seen for the diarrhea and mom is sitting there and she's feeling woozy and she's all dehydrated and then she faints and she doesn't lay down. So she might have a couple mild clonic jerks or syncopal seizures, jerks until they lay her down. We know that most likely that is from the low blood pressure because she's hypovolemic. And if she does absolutely great with volume, then it is very possible that that should take care of business. Fluids treat or not bradycardia, pressors, none of the above. It all depends on the mechanism. Now, this is not anaphylaxis. Is this a similar mechanism? No, this is a sudden lack of sympathetic tone. So what's happening is our brainstem is sending a vagal surge to the heart to slow it down. And also it's turning off the sympathetics to the legs to maintain our pressure. So all at once with a vasovagal episode, the blood pressure drops and the heart rate slows. But what do? You lay them down. Laying them down should take care of that. It is not similar to anaphylaxis. Supportive care is most typical for syncopal seizures. I hope that's good for COOS. Any other questions?
Looks like there's one more question.
One more question? Okay. I
from
have,
Crystal Bull.
okay, what am I missing here?
It says, my sister-in-law has Down syndrome and nonverbal, and 4 years ago had her first seizure
I
at the
see.
age of 60. Is now on Keppra and calm the electricity in the brain.
Right. So let me make sure I read this right. My sister-in-law has Down syndrome, nonverbal, and 4 years ago had her first seizure at age 60. That's incredible that she has Downs and she's made it all the way to age 60. That's such good news. She's now on Keppra to calm the electricity in her brain. There's lots of etiologies for seizures in a 60-year-old. And again, the neurologist can evaluate that to determine what the cause is. It isn't necessarily that she has Downs, maybe something true to and unrelated. For example, she might have had a small stroke. She could have vascular ischemia, in other words, for a lack of blood supply to her brain. Yeah, they probably will image her, look for a structural lesion, and then treat her. Hopefully
I
that can
remember brain tumors is when you all of a sudden a new onset of a stroke, or not a stroke, of a seizure in someone who's over 60, you start thinking
That's
about
exactly right. Yeah, she'll get a CAT scan looking for a focus like a brain tumor. Yep.
Please, everyone, remember to, if you would like to get continuing education credits for this, to check the chat, hit the link and send your information. After the fact, once it closes out, it can't go back in retrospect at this point. But now would be the time if you have not already done so.
Do I need to click on this too?
No, you're good. You don't have an EMS card. I'll get you
All
something
right.
for CMA if you want.
No, that's right.
For the ABA.
Okay, no, I'm good. I'm good. All right. Well, thank you, everyone that's still there, for inviting me to the party so I can be with the cool people.
Thank you very much, John. It's
You're
always a
welcome.
pleasure.